interaction in medical encounters. And to set up the project, I'll explain how a linguist comes to look at ethics in medical encounters. And the reason is that in medicine, bioethics is typically considered the top-down set of ethical principles, autonomy, beneficence, justice, that should normatively underlie decision-making, medical decision-making. But medical decision-making with ethical dimensions most often takes place in interaction among real people in real time instead of semi-ordinary language that is often more indirect and direct, and in complex contexts that are institutional and asymmetrical. Yet the actual language of medical decision-making with ethical implications has rarely been studied directly in literature, and a bottom-up perspective on ethics as interactional and rhetorical is only beginning to emerge in discourse studies. So the central descriptive questions for this research program are: how are ethical issues raised, explored, negotiated, justified, and settled or not in medical decision-making, and how does the discourse of medical encounters thereby construct and reflect ethics in interaction? The theoretical framework for this program is a minimal but generative one. I use Serenity and Roberts' 1999 distinction between institutional orders and interactional orders. And briefly, institutional orders seek to regulate professional practices, including communication and decision-making, in order to achieve accountability to the policies of the institution. So here, think bioethics incorporated into hospital policies. Interactional orders are the conventionalized discourses of particular communicated events where decision-making actually takes place. And as part of their professionalism, physicians acted with control and control of the interactional order. This framework allows the exploration of interesting theoretical concepts and tensions revolving around authority, accountability, professionalism, agencies, boundaries, control, resistance, persuasion, coercion, and so on. So I want to give you the methodological reasoning for this program. My method is discourse analysis, linguistic discourse analysis. So my central descriptive question specified is what are the linguistic means by which ethical issues are negotiated, explored, etc. in medical decision making. And there are 4 things that I think make this framework impossible and important. First, following Schoen's 1983 conceptualization of practitioners enacting thought in action, the expertise and experience in everyday action, and for our purposes, interaction, McGrath, Henderson, and Howell, 2006, suggests that physicians enact medical ethics relatively unself-consciously in everyday clinical practices, including, again for our purposes, shared decision-making with patients and families. This shared decision-making with ethical dimensions often takes place within conventionalized discourse events, repeated and rhetorical, institutional, and interactional genres such as treatment plans. Within these interactions, physicians conventionally index the basis for their clinical and ethical decision-making, and families and patients and families sometimes do as well. Based on Pirikaila's 1998 analysis of the linguistic conventions physicians use to point to the basis for a diagnosis, either directly or inferentially, for example, with locutions like it is X, it seems likely, or may be X, the test showed X. I use the term index to describe the linguistic conventions physicians and patients and families use to point to the ethical basis for decision making. Indexing is often an expression of accountability. Physicians to medical ethics and bioethics, and patients and families to their own bioethics that they bring to the account. The importance, I think, of this framework is a bottom-up discovery process to describe the ethical assumptions, questions, reasoning that participants actually bring to medical decision-making, thereby by complementing and or challenging top-down, hypothetical, case-based, dare I say, philosophical approaches. So the data for this project comes from observational and interactional data in the form of transcripts from ethically charged family events. And today we're going to talk about 2 of those projects. One is on end-of-life discussions, and the other is on authors who participate in clinical trials in cancer medicine. And this is a meta presentation because we're in a humanities center. So I thought I would talk about emerging themes from all of this with linguistic discourse analysis. And I brought you a handout because the themes are rather dense. But I'll read them as this is going around. Interactional attention to ethical issues is distributed across communicated events rather than concentrated in specific decision-making sequences. Physicians and families and patients and families index the ethical resis for their decisions, sometimes differently and sometimes similarly. Decision-making is less often an explicit sequence and more often an implicit trajectory of interactional alignment or non-alignment. The use of persuasion is a key ethical issue for physicians, reflecting the tension between bioethics and traditional medical ethics. And research on ethics and interaction disseminates information that points to unethical as well as ethical ways of managing the interaction of ethically charged decision-making discourses. So the presentation, which takes 30 minutes, is as follows. I'm going to talk about the end-of-life project with respect to themes 1, 2, and 3. And I've never talked about the end-of-life project at the Humanities Center before, so that's new for us here. I've talked about the clinical trials project in the Humanities Center's presentations before, but Andrew is going to present some of our new analyses with respect to themes 3 and 4, and then I'll come back to conclude with respect to theme 5. Okay, so turning to end-of-life discussions. The data for this project came from a corpus of 20 end-of-life discussions withdrawing life support from patients in a surgical intensive care unit. 14 of these discussions moved to a decision to withdraw life support and 6 did not. Some essential background. An end-of-life discussion is a goal-based institutional discourse in that physicians do not initiate an end-of-life discussion unless the goal is to move from therapeutic to palliative care, thereby allowing the patient to die. So the findings of this project that we'll talk about today are, first of all, a description of the structure of an end-of-life discussion. End-of-life discussions have 4 phases with distinct structures and functions. Phase 1 is the opening, in which physicians and families co-construct the traditional role structure of a medical encounter with physicians in the interactional unit. Phase 2 is a description of the current status of the patient. This is a presentation of medical information, most often, well, always organized as a problem list, culminating in an inferential summary statement of terminal status. Phase 3 is, ideally, shared decision-making, short and inferential decision-making sequence indexed to patients' wishes. And phase 4 is logistics of dying, where physicians and families co-construct a combined medical lay discourse of palliative and comfort care. So the findings that we'll also talk about today are the following. Physicians always indicate medical futility as the ethical basis for a decision to withdraw life support in phase 2, followed by bids for inferential decision-making in phase 3, indexing the patient's wishes. Families often index the loss of personhood and or consciousness as the ethical basis for their decision-making in phase 4. And physicians and families co-construct a discourse of the right decision in phase 4. So for this project, we're going to argue by example. Okay. So here is an example of a phase 2, phase 3 end-of-life discussion with a trajectory of alignment. And I'll give you a minute to read that. Okay. I think what's happening here that is in 1 is that the physician is presenting a phase 2 inferential summary statement of terminal status indexed to medical futility, followed by a phase 3 bid for inferential decision-making with the single word but. The family then provides latched agreement provided using the same single word but and a reformulation in lay language. And this is the sequence that served as inferential decision-making in this discussion. In 3, the physician makes a bid for alignment indexed to the patient's wishes. The family provides simple agreement in 4. In 5, the patient or the physician provides a second bid for alignment indexed to an elaborated frame of the patient's wishes, and the family provides simple agreement again. This is a masterpiece example. It is so well aligned that I can hardly stand it. Okay, now I'm going to show you a phase 2, phase 3 with trajectory of non-alignment. Okay, so I'll give you 30 seconds to do that one. Okay, in 1 here, the physician provides the phase 2 inferential summary statement indexed to medical futility, followed by a phase 3 bid for inferential decision-making in medical terms. So goals of treatment means quite a bit if you're working in an ICU. I'm not sure what it means in the context of a needs discourse, medical discourse. But what the family provides here is okay, a neutral continuing, overt agreement to the discussion only, but no uptake of the bid. In 3, the physician retreats with a marked pre-closing sequence. Okay? And in 4, the family member is silent, again with no uptake. This is an encounter that's not very well aligned. So we chose continuing examples for you to see here. So family contributions are minimal in phase 3, whether aligned or non-aligned. Simple agreement and positive continuers most often construct a trajectory of alignment. Silent and neutral continuers construct a trajectory of non-alignment, as does open disagreement, although the latter is rare in institutional and medical discourse. Although we have one example of it, if you would like to see it. Okay, now we're going to turn to phase 4. Okay, so that's decision-making, index decision-making, in terms of its interactional alignment. So phase 4 is the longest and most interactive phase of the end-of-life discussion, with families at times in the interactional lead, for example, initiating topics. In phase 4, families index the ethical bases for their end-of-life decisions, and if aligned, physicians and families co-construct a combined medical lay discourse of palliative and comfort care. Okay. So examples here are first a phase 4 with a trajectory of alignment indexing consciousness. So I'm going to read 1. If she's not in any pain, if she's not struggling with, if I'm standing there, I don't want to see her going through this because that would make me feel like I made the wrong choice if she's trying to catch on. So in 1 here, the family indexes possible consciousness as the ethical basis for decision making, the wrong choice. And in 2 and 3, the family co-construct the right choice, if I could use that phrase, with the family in the interaction lead. The family initiated this topic, and the family actually issued a directive in 3. Now we'll see a phase 4 alignment with indexing the personhood. Okay, so the family says here, initiating the topic, if you had known her, you would know that we're doing the right thing. So in 1, that's an index of personhood as the ethical basis for the right thing. Okay, and in 2, the physician indexes the medical perspective, futility, okay, as the ethical basis for the right thing. So that's a very smooth co-construction. Now, one of the odd things that happens in end-of-life discussions is there is trouble in the action, in the interaction. Either the family doesn't accept the problem list or the summary statement, or there's no decision in phase 4. Then the discussions nonetheless progress on to a hypothetical phase 4. This really surprised me, but it happened a number of times in the corpus. So I'm going to just show you a hypothetical phase 4 with a trajectory of non-alignment. Okay, there are often recursive bids for decision making in hypothetical stage 4s. But here we have a mother talking to her daughter on the phone, and she says, she's dying, I know what's going on. Well, I have to make a decision to pull the plug. I hate to. And the physician says, you don't have to do that yet. So here in 1, the family member's prediction of solo and reluctant decision making indexed to the lay formulation that she's dying, but not indexed to the patient's wishes. And the physician immediately retreats in response to a lack of alignment in non-shared decision making. So with respect to our themes, with respect to theme 1 about interactional attention being distributed across communicating events, what we've seen is that phase 3 is the decision-making in end-of-life discussions, but interactional attention to ethical issues is distributed over phase 2, 3, and 4. With respect to indexing, okay, what we've seen is that in phase 2, physicians index medical futility, and in phase 3, if aligned, both physicians and families index patients' wishes. Okay. In phase 4, families index person-centered consciousness, and again, if aligned, both physicians and families co-construct a combined medical lay discourse of the right decision, multiply indexed. And with respect to theme 3, decision-making as a trajectory of alignment, what we've seen is phase 3 with its short and indirect and inferential utterances, whether aligned or not.
Moving into the offers to participate in clinical trials. Here, we were working with a corpus of 22 medical oncology encounters which included clinical trial offers, matched to a sample by ethnicity, both African American and Caucasian American. 14 of these offers resulted in a preliminary decision to participate in the clinical trial, while 8 did not. Now, to give you some background on clinical trials are the gold standard in medical research. However, too few patients enter trials, especially minorities. So the chief ethical issue here is the blurring of the lines between standard treatment and experimental research, what we call the therapeutic misconception. So there's considerable tension between the institutional order of bioethics and the interactional order of traditional medical ethics. And to give you some examples, the American Medical Association says that physicians should be completely objective in discussing the trial. They should not use persuasion to obtain consent. So from a bioethical framework, this position licenses a discourse of autonomous decision-making, while the National Comprehensive Cancer Network says that the best management for any cancer patient is a clinical trial. Participation in trials is especially encouraged. So from a traditional medical ethical framework, this position licenses a discourse of persuasive decision-making. So what physicians often do is they construct trial offers as a hybrid discourse that draws upon both perspectives. Now, some of our findings. First of all, we found that offers to participate in clinical trials are flexibly structured, and they're a specific topic within the oncology encounters. And they include the purpose of the trial, procedures, risks, consent, logistics, and questions. Secondly, we found that physicians regularly mention direct benefits and use other persuasive strategies in the discourse of the trial offers. So, for example, the placement of a trial topic and topic openings and closing, which are the two topics which I will address today. Finally, we found that preliminary decision-making to participate or not in a trial is often a trajectory of alignment or non-alignment, sometimes indexed for reasons to participate. I'm going to begin with topic placement. So in medical encounters in general, the treatment plan ends with logistics before a general closing. In 19 of the 22 encounters we analyzed, the offer is the last topic within the treatment plan. So the move to logistics presents the logistics of the trial, not any of the treatment alternatives. In 15 of the 22 encounters, the offer is the last topic before the general closing, also creating a structural momentum leading to trial participation. To give you a quick example here, this is a good example. The physician here, in number 1, answers the family's questions relating to the trial. In number 2 through 4, the patient and the family co-construct a trajectory of alignment to participation with positive continuers and inferential agreement, the okay, okay, okay series. Then in 4 through 6, the physician moves into the general closing of the encounter with the logistics of the trial treatment. So that's topic placement. To move to topic openings, our analysis of topic openings found that physicians use a continuum of persuasion, and most frequently they open the trial offer by mentioning several different elements, but most often medical research. And what we want to do is take a look at how they use these 4 elements in either neutral or persuasive ways along this continuum of persuasion. And first of all, we want to take a look at how they use neutral versus persuasive medical research or the purpose of the study. So in 1 here, we have a relatively neutral opening. We have a bunch of different drugs in which what is the best first drug or combination is still under debate. How to mix and match them the best way is something we're still studying. It's a description of the trial. However, in 2, so the study is, the purpose of the study is to prevent the cancer from coming back, constructs the purpose of the study as in terms of a positive hypothesis only. It's a more persuasive opening. In previous medical communications, physicians do a similar thing. So in number 1 here, we have a neutral, did Dr. So-and-so mention that we had a new research study? Whereas in number 2, so he suggested you go on the Sutan trial. So based on what they said, we should go on the new drug. Incorporates treatment recommendations into the previous communication from another physician. Another element that's in the openings is the eligibility or the availability of the trial, which is the second set of examples here. The first example, number 1, is just an introduction to the research study. Whereas the number 2, okay, well, that brings us to the clinical trial you are a candidate for, positions participation positively as an opportunity for the patient. Finally, physicians sometimes use treatment recommendation as a way of opening the clinical trial offer. They can do this in neutral ways, number 1, or rather persuasive ways, 2 and 3. Most likely I'm going to suggest that you participate in one of our national studies, or we have a study of that would also, I think, be a very good option for you. So here they construct it as a direct recommendation to treatment. Now, breaking it down between the African American and Caucasian American, the only significant difference we found that was interesting was that in terms of these direct treatment recommendations, there were 3 to African Americans, whereas there were only 1 to Caucasian Americans. So what all this illustrates is that topic openings establish a frame or a structure of expectations for interaction. Persuasive openings and trial offers conventionally establish a positive perspective on participation in medical research, which reflects this tension between bioethics and traditional medical ethics in the interactional order. Now I want to move to a discussion of decision-making and the way that patients and physicians co-construct an index trajectory of alignment. So like the end-of-life discussions, preliminary decision-making in trial offers is often short and sometimes inferential, with agreement constructing a trajectory of alignment or deferral in response to non-alignment. So here's an example that incorporates both a deferral followed by a decision. So in 1 and 2 here, the physician first bids for decision-making, what do you think? And it is met by silence. So, in 3, taking silence for non-alignment, the physician defers. I'm not asking you now whether you want to commit to being on the study. However, in 4, the patient decides to go on the trial. So immediately in 5 through 8, the physician moves into logistics and questions to close the topic. We have both the deferral and the agreement to participate. So, in 11 of 14 decisions, we found that patients or family members indexed the reasons for participating in the trial. They did it in a couple different ways. So first, research. In 1/3 of the cases, they indexed research in their decision to participate in the trial in terms of participation. Whereas in 71% of the cases, they indexed treatment, mainly in terms of recurrence, survival, and general treatment. However, with physicians, unlike the end-of-life discussion, they construct a trajectory of alignment which sometimes mirrors the patient or family member's reasons and sometimes reformulates them. I apologize, this is a little out of focus here. But what we found here is that in, again, almost 1/3 of the cases, physicians index research, but here they do it in terms of you're a good candidate for the trial, or this is a good trial to participate in, or sometimes in terms of consent. Whereas when they index treatment, which again they do in about 2/3 of the cases, it's more in terms of logistics of the trial instead of recurrence and survival, which is the way that the patients index. To give you some examples, this first example it shows decision making with a trajectory of alignment indexed to recurrence. So in moves 1 through 3, the patient indexes research participation and recurrence. And I definitely want to participate because I don't know whether the cancer is still in my body. In 4 through 6, then, the physician constructs a trajectory of alignment by first reformulating the patient's decisions in terms of a good treatment decision. Yeah, well, I think it's a good idea for you to have further treatment. But note that no explicit uptake to recurrence happens. I think that this is a trial worthwhile participating in. So preliminary decision making here is the basis for informed consent. That was alignment. Now let me show you non-alignment. Here's decision making with a trajectory of non-alignment. So here in number 1, there's a description of the trial in terms of how many trips per month the patient will have to return to the cancer center. In 2, there's no uptake. In 3, there's repetition in response to the lack of uptake in a bid for alignment. So being on the study would be a little more involved in terms of travel, okay? In 4, the family responds by identifying transportation as the biggest problem, the biggest obstacle to participating in the trial. And then in 5 through 9, the physician and family co-construct an indexed decision not to participate in the trial. So it's preliminary decision making as a basis of informed refusal of the trial. So to return to our emerging themes, reference to theme 3, that decision making is less often an explicit sequence and most often an implicit trajectory of interaction, alignment, or non-alignment. Here we found that decision making, as with the EOL encounters, is short, sometimes influential, and aligned or not. In reference to theme 4, that the use of persuasion is a key ethical issue for physicians, reflecting the tension between bioethics and traditional medical ethics, we found that topic placement, opening, closing, and development with indexing can be used as persuasive strategies designed to support preliminary decision-making to participate in the clinical trials. Secondly, we found that through indexing, patients and family members foreground treatment over research, while through reformulated indexing, physicians align treatment and research.
Okay, so I'll talk a little bit about the implications of this work in terms of theme 5, which is that research on ethics and interaction disseminates information that points to unethical as well as ethical ways of managing the interaction of ethically charged decision-making discourses. So first for the EOL project. For this project, I think the research provides a better understanding of the ethical basis for end-of-life decision-making and the means for co-construction of the right decision in phase 4, with the suggestion that physicians should attend to the family's lay ethics of the loss of consciousness and personhood, making one of the functions of phase 4 ethical reassurance. The research on this project though also points to ways to appropriate and thereby short-circuit, for physicians to appropriate and thereby short-circuit family reasoning and agency in phase 4. Physicians could shorten phase 4 considerably by appropriating topics of consciousness and personhood, but efficiency is, or may not be, the most ethical goal of this phase of the end-of-life discussion. In the clinical trials project, we think that the research points to a better understanding of the reasons for participation in trials. Patients and families do index and therefore foreground individual treatment and decision making, but physicians can contextualize this decision, making the function of their indexing and ethical reformulation to this hybrid discourse of treatment and research. Also for the clinical trials project thus far, I think the research points to a better description of the persuasive strategies that physicians are actually using in trial offers, and I think that can open a discussion of ethical and unethical persuasion with a question for future research of when does persuasion become coercion. Okay? And this is important because if you think back to the AMA position that Andrew cited earlier, totally objective. If Beecham and Childress call this an informational base, I think that this work is a challenge to that, in a good way. Okay, but this research on the clinical trial also points to ways to identify and use, or for physicians to identify and use effective persuasive strategies and reformulations without meaningful ethical contextualization. Okay, thereby foregrounding the institutional goal of enrollment over the interactional goal of shared decision making. So here are the payoff questions for this project in conclusion. Thinking positively, what does research on ethics and interaction provide? Better understanding of the ethical dimensions of decision making for physicians as well as patients and families. And thinking more problematically, what does this kind of research provide? It provides ways for physicians as well as patients and families to manipulate decision-making discourses. And I think some of those implications are obvious for physicians, but I will tell you just one story about patients and families. I don't think patients and families, despite some of their massive internet searches, are really looking at linguistic research on clinical trial offers. However, okay, if you want to be a patient on a phase 1 trial, I can tell you how to be persuasive in that context, right? And I could go to community events and disseminate this kind of information. So one of the things I like best about this project is that it incorporates research not only on physicians but also on patients and families when we start thinking about ethics and medical encounters. Thank you.
Time for questions and comments, reactions.
One situation, you have 3 parties. One of them is the patient dying, who may have left a living will or expressed wishes ahead of time that can be referred to. The other 2 are the physician and the family members. In the second case, you just have the physician, and the family position is both that of let's say, the interactional participant that you have in the first case, but also the person who's ill or being talked about. So that alliance means something different, or alignment means something different in those 2 cases, right?
Well, let me address your first comment, which is when I was working on this project, I analyzed the data for references to living wills. And only families referred to living wills, and it was a kind of indexing for end-of-life decisions. So we didn't talk about that here. Physicians never referenced living wills, or as families sometimes call them, papers. Okay? And there's a kind of a very interesting, very shocking research study a number of years ago that showed that physicians in the emergent care, the acute care setting of an ICU, would follow their clinical judgment rather than living will documents. So that is brought up, and physicians typically kind of finesse it, and again, not out of the unethical idea or this challenging my authority with living wills, but in the larger context of that kind of care. So I wanted to say that about living wills and such. In terms of the different configurations, those of course differ for every single case. But family doctors usually weren't present in these discussions. You know, once a patient is in an ICU, he's the responsibility and under the authority of the attending physician in that context. So there can be phone calls, but there was in the corpus no family doctors attended, chaplains attended, nurses attended, but you know the ICU is its own world, and the ethnography of the unit that I worked on, which is a wonderful book by Joan Castle. She calls it a moonscape. Okay? And it's hard to get to the moon if you're a family physician sometimes. So they're not well incorporated into that discourse.
Well, one of the reasons I brought up the 3 versus 2 is that in the case of end-of-life decisions, the family members who are responsible for making decisions are making decisions based upon the supposed wishes of the person who can't speak for himself or herself,
Right.
and the judgment, the ethical judgment that he's making.
Right.
So that bringing those 2 things together is a more complicated situation than perhaps the clinical trial decision, where the person is ethically responsible for himself or herself making a decision about what to do.
I don't know that I would call one of these more complicated than the other. I think they're different. The striking similarity is in the decision-making sequences, and in the discourse is hybrid in terms of incorporating both bioethics perspectives and traditional medical ethics perspectives. I don't know that 2 versus 3. I'm not sure. I'd have to think more about that. What's interesting sometimes about the clinical trial office is that, as you can see in the first example we presented, it was the family members making the decision, which is not at all unusual either. So I'll have to think about 2 versus 3. The PI for this project over at Carmanos is doing an enormous project on the effect of family members in a couple different projects. One is the effect of family members on clinical trial office. They're looking at how many questions are raised, who raises them, and so on and so forth. Yeah. And the other one is on family members when children are undergoing painful procedures over in children's. So there's a lot of new work on, the effect of family members on decision making in medical encounters, other than the old saw that the wife answers for her husband, which is part of the clinical jokes about medical encounters. Liliana?
Yes, I was just wondering, you said that there are ways for the physicians to become more persuasive by focusing on treatment as opposed to research. And I'm just wondering how that then aligns with the ethical. Does
Right.
becoming more persuasive become less ethical? And also whether you found a correlation, or if you're even looking for correlations between, how you present the case and what the outcome is.
Well, that's the huge issue. And in the bioethics literature, the literature is enormous. This is the central issue of offering participation in research is whether is it a decision that is presented correctly as one not only of treatment but also of other things. To go into a trial where the efficacy of the regimen is an open question. Okay. But it's not that simple in that by the time you get to a phase 2 or 3 trial, there's a lot of evidence, okay, for efficacy, and I think we have to sort out the cases. We can do that. For example, the example where the patient threw up his hands and said, "I've got to get rid of this out of my body." That was a trial in which the alternative was, it was taking low-dose chemotherapy for a really high-risk cancer, high risk of recurrence, or no treatment at all. The standard treatment in that case was no treatment at all. And so that's a an example of one case, whereas, the question, the example that Andrew showed of the mix and match, that was a breast cancer case, and there, there's whole bunches of different choices that you can make. But as far as analyzing the statements for persuasion to see whether they would work, I did do that in the end of life discussions, but, I could do that for the clinical trials, and probably will. I mean, I think that's important information, but it troubles me, to think that I'm contributing to less than the best medical communication. Kat?
I was thinking on similar lines, and the family doctor is a different individual that has had usually extensive history with the family. And having just been involved in one of these situations in rural environments, the family doctor is almost always involved, even if there's an ICU, and even if the person is in a hospital far away. The family doctor makes a point, because they've usually been with the family for a long period of time, and even in this community, I think that's true. It's that, and alignment would have, I think there'd be almost a qualitative difference if the family doctors were involved. In terms of use of the patient's wishes, that patient's, at least in the environments I know, and I'm thinking of a few people, have talked with their patients about this, their personal physicians. And so both the family and the physician would be on the same page with that. And so I think that the decision process would happen a little differently if that personal physician were involved.
Yeah, I think you're right in your first point. These data are taken from a huge teaching hospital, and that's a very, that by the time we get to a surgical ICU, that's narrow down. But I'll say two things about this particular corpus, and one is that physicians will sometimes ask the patients to say what the family doctor thinks. Now that didn't happen very often, but it could be a bid for alignment, as you and I have discussed. The other thing that happens is, I think that when there is communication between the physician and the family physician, it happens by phone. And it's, I would have to go over and look at the data again with that specific question in mind. I would say that in this data, physicians did not use that as a resource. Karen?
When I look at these examples, and I understand your quandary about presenting this as this is the way these go. But I wonder if you'd care to comment about the whole notion of enrollment in a clinical study and the notion of informed consent, where some of those seemed as if the participation was elicited before they got to anything that would even smack of informed.
I've written about that, and again, I think, I think that the data would support an interpretation that consent, in terms of the consent form, in terms of informed consent, is truly marginalized in these discussions. That's why I call it preliminary decision making. I also think, when I'm being totally honest, that physicians can finesse consent. And what I think, what I think that the physicians are doing here is, I think that they are sort of taking advantage of the discontinuous nature of medical communication to separate the offer from the consent. And whether you think that's a finesse or whether you think that's marginalizing consent, is arguable. But what nonetheless often happens is that there will be this kind of discussion that we saw in these examples here, okay? And then if there's interest, and that's the locution people use, if you're interested, then one of the first things that happens is that a formal consent encounter is set up for the patient and the family. So I think I think this is a good example of physicians controlling the interactional order, okay, in that the offer is presented typically by the physician, the consent encounter is often presented by the research nurse on the study. Now, whether you think that is a problematic marginalization or not I think it's a good question.
Yeah. Well, it does raise dilemmas when you serve on the HSC. But,
Sure. Well, we can talk about that too.
we have, isn't it?
But there's some of that in every offer to be in a research
Sure.
project.
Right. It's like,
Do Site 101 students,
right.
if they can increase their grade potentially by doing some of this, do they, by the mere signing up and showing up at the lab,
Right.
they're in some sense doing what these patients were doing, saying, I want to do this. And then they're presented with a consent form.
Right.
And do they really read it? Do they really listen when it's read to them? I mean, I've done this for years. No. They're signing their name while they're reading it to them and explaining it to them. I'm not sure, these were much more emotionally charged, but
Yes.
I'm not sure it happens in.
No, I agree. And I think I have my own theory about it, which is that, and I don't know, well, I know how to investigate this as a linguist, but life is short. I think the consent form has negatively impacted the process of informed consent. Because what the physicians in this data typically do is they say, well, I'll leave you to read the consent form. And then they go out of the room and come back. Or they'll say, and sometimes they combine it with a deferral. A deferral is a highly ethical, or it can be interpreted as a highly ethical act. And they'll say, well, I want you to take this consent form home, and I want you to think about it, and do your research, and we'll talk about it when you come next time. So, and all of those things can be interpreted. and again, that's the nature of this program. Sometimes I say in casual conversation that my research can help people in a lot of different settings become both unethical and efficient. That's just what it ends up. Michael?
Yes, speaking of informed consent, it made me think of those television commercials for new drugs.
Oh, yes.
And they'll have this very sweet music playing, and then say, oh, this can cause death. Fatal bleeding, and all this. And they're advertising for it. And so.
And who listens to that? I think you're absolutely right. And I think that's a function of the regulations for product labeling and consent form. The consent form in most of these trials here are 22, or as a physician said one time walking into the room, the consent form is only 22,000 pages. It's written, they've done readability studies. I even did a tiny readability studies of our forms because we were trying to work on templates. And the reading level of the consent form is postgraduate. So it's, and I mean postgraduate, right? So the consent,
what you're asked to do.
right? The consent form is. To tell you the truth, I've avoided it as a lifelong project. I sort of, because I don't know how you make any progress. Now, maybe the new regulations.
I'm more interested in the notion of idea of informed consent than I am the sort of
Well,
logistics of it.
most of the literature on enrollment in clinical trials is in terms of informed consent. And I've read all that literature. And the problem is, to me, if you believe that decision-making in the offer is what matters, is that the decision. Then the informed consent encounter becomes pretty uninteresting because you're not making any decisions.
The other thing I wondered about was, you mentioned that family members, the patient, the doctor, occasionally but rarely the family doctor, and then you mentioned members of religious communities. And I wondered if there was enough of that to do.
There's not enough data, they don't speak in the meetings. What you need to do there, and again, this is just logistically so challenging. I would love to do it, but it's impossible, is you need to have bedside communication. And that's what you need if you want to analyze nurses' role in this process, which is significant.
Which is,
And the same is true for chaplains. But in the meetings, there's only one example of a nurse, and when I was first working with this team, that was the example I chose to present at my first meeting with this whole team, was a nurse making an intervention to a physician conducting an end-of-life discussion. And that was virtually the only example of a nurse talking in those meetings. Again, go back to this notion of interaction of order. It's very interesting to think about medicine when you think about what do physicians take steps to control. Okay? They take steps to control end-of-life decisions. They take steps to control clinical trial offers. I think that's interesting. That's why I use the term physician and not clinician, right?
And there's so little retained by the patient, or the
Right.
family. They're in a crisis, there's stress, and maybe 10–20% of the information is actually retained. So that's another variable.
Yep. And they have studies of that. Small?
Do you have any follow-up of these cases? Like, do you know which patients left feeling like they had been an equal, like a kind of co-equal partner in the decision, which ones felt coerced after the fact?
There is no satisfaction data for the end of life. There is satisfaction data of a sort for the clinical trials, and that's on the long list of the next projects. And also, actually, it's kind of interesting because there's data available about whether the people signed up for a trial or not. And so I have never looked at, because in Terry's group, they're looking at, there's a surprising difference between what when a physician says, oh yes, I offered a trial, and then they say, ask patients in the interview afterwards, were you offered a trial? And the patient will say, I don't think so. And vice versa. So there's a lot of data on that, and Terry's team is looking at that. So, yes.
On the end of life ones, those were just SICU?
Yes.
Okay. Have you thought of expanding it to like trauma or
Sure.
other end of life?
You bring me the data, I'll do it.
I'll shake deep enough.
But you have to do it via HAC.
Do you think there'd be a marked difference between a trauma physician versus a SICU physician?
I don't know, because I don't have,
That'd be interesting.
it would be, it would be, but I just,
Next
I have no data on TV shows.
Well, you should talk to,
Zelensky,
the several
I know.
indies who do qualitative research